Welcome, everyone. Happy Wednesday, November 9th. Please take a moment as you are setting up your sound to rename yourself according to what you registered as. So, for example, my name is Ty Edward Few. If I registered as T Money, please go ahead and set your name as T Money so we know who you are and we can check off our attendance list. Good day, and we will get started in exactly 1 minute. Take this time to get your sound set up. Also, it would be great if everyone can put your name and pronoun and organization in the chat. For example, my name is Ty Edward Few. My pronouns are he and his. I'm with the Denver PTC, and I'm going to put that into the chat. We would like to just see all this information flowing through our chat. Welcome, everyone. Happy Wednesday, November 9th. We are so happy to have you. My name is Ty Edward Few. My pronouns are he, him, his. I'm the Learning and Development Manager for the Denver PTC. And it is my pleasure to welcome you to this webinar, Gender Affirming Care for People Living with HIV. We're going to have a great learning opportunity today. I'm happy that everyone can be here. I'm going to turn it over to our facilitators today, Dr. Riley Smith and Dr. Sarah Rowan, and ask them to introduce themselves, and we will get started. Thank you, everyone.
Great. Thank you, Ty. Welcome, everyone. It's a pleasure to be here with you today. Thanks for joining us and our webinar on providing gender-affirming care to people with HIV. This 90-minute webinar will provide participants with the knowledge, tools, and resources to provide high-quality and culturally responsive gender-affirming care while providing treatment and support for transgender and non-binary persons with HIV. Through case examination, this webinar demystifies the process of prescribing ART and HRT to transgender and non-binary persons with HIV, and just demonstrates how to manage drug interactions and discusses considerations for healthcare maintenance and preventative screenings. Riley, can you introduce yourself?
I'm Dr. Riley Smith. I'm a family medicine physician practicing in North Carolina, where I provide full scope primary care to a diverse patient population, including prescribing gender affirming hormone therapy and primary care for people living with HIV.
And I'm Dr. Sarah Rowan, and I'm an infectious disease specialist practicing in Denver, Colorado, where I provide care for people with HIV, hepatitis C, and other infectious conditions. A quick note about the presentation. We're going to be discussing medical topics, like labs, medications, and cancer screening for transgender and non-binary persons with HIV. The majority of this information is gathered from professional societies and professional guidelines, primarily the World Professional Association of Transgender Health Standards and Care 8, the University of California at San Francisco Guidelines for Primary and Gender Affirming Care of Transgender and Gender Non-Binary People, and the HHS Guidelines for the use of antiretroviral agents in adults and adolescents with HIV. These are all very helpful tools for incorporating this care into your own practice. If at any point in the presentation, the topics of discussion are not covered by the guidelines, we will make clear that we're providing expert opinions and non-medical advice on any specific patient. So the learning objectives for today are to identify the benefits of integrating HIV and gender-affirming care for antiretroviral therapy adherence, and describe 3 possible cross-departmental referral models, name 4 drug interactions between ART and HRT, Describe considerations when prescribing HRT for persons with HIV, including naming medications used for hormone therapy and baseline and monitoring labs. And finally, to describe 6 healthcare maintenance and preventative screenings for transgender and non-binary persons with HIV. Next slide. You can see our agenda. We'll have a few poll questions for the group and other points throughout the webinar where we will ask for audience participation and provide opportunities for questions. We also encourage you to share your experiences or ask questions throughout the webinar. And please feel free to type in the chat box or to raise your hand using the Zoom icons. So turning to our first poll. The first poll question is, what best describes your experience and or role in caring for transgender persons living with HIV, transgender and non-binary persons living with HIV?
We have a lot of responses coming in, Sarah, so some of our items are building up. The poll will be open for the next 30 seconds, so go ahead and try to answer.
Terrific.
In these last 20 seconds, go ahead and find your response. And Misty, I'm going to ask you to close the polls and show us the responses.
All right, so can everyone else see the responses here? It looks like we have a lot of folks coming from really all over. So we have a few providers doing different levels of HIV care and gender affirming care, some staff members at different clinics doing, again, kind of different variety of care. And then a handful of folks who are not working in a clinical setting, which is great. And so we're hoping to target sort of different parts of this presentation to everyone, kind of no matter where you're coming from at this. And then we have one more question.
Our next question is, what services are currently offered in your practice setting?
Looks like about a little over half of our people have responded. We'll leave it for another 20 or 30 seconds here.
All right, Riley, I am going to close the poll and share the results.
All right, so again, thank you for everyone for your responses. Again, looks like folks are really coming from lots of different places. So some people doing exclusively HIV care in their clinics, a lot of people doing kind of a combination of care, and then some doing more of like a referral system, and again, some folks who are not in the clinical setting. So thank you all, and feel free to, again, contribute kind of your own experiences and perspectives as we go through the presentation.
Perfect. Well, we will move on and talk about the importance of providing integrated care. So we'll look at why, as we consider the importance of integrating HIV and gender affirming care, thinking about the significant disparities that exist. We know that transgender people, particularly transgender women of color, are disproportionately affected by HIV. This is not a surprise to anyone who cares for persons with HIV. In 2015, one of the largest national surveys of transgender people in the US found that respondents had 5 times the rates of HIV compared to the general US population at 1.4% versus 0.3%. Of the 36,800 new HIV diagnoses in the US in 2019, 2%, which represented 671 people, were among transgender people. And the majority of those diagnoses were transgender women, with 7% of them among transgender men. The infographic here is from a national study of transgender women in 7 cities from 2019 to 2020, which found that 42% of transgender women interviewed were HIV positive, with the highest prevalence amongst Black transgender women, really underscoring the critical nature of this discussion, given the disproportionate impact of HIV among transgender women. And we also know that the incidence of HIV, or incidence being the number of new diagnoses each year, has increased for transgender women and transgender men as well. This graphic shows that from 2015 to 2019, the number of new HIV diagnoses for transgender women increased by 5%, and for transgender men increased by 44%. Though of note, the absolute number of transgender men included in this data was low, so the CDC recommends caution interpreting these results. For comparison, new infections decreased 10% in cisgender men and 7% in cisgender women, underscoring a real disconnect in trends among transgender and cisgender persons. In this slide, we look at care for transgender persons with HIV from 2019 data, and we see that transgender women and men had similar, if not better, rates of receiving care, retention in care, and viral suppression compared to the overall population of people living with HIV. However, these rates are still not at our goals, and more work is needed to improve them. We'll explore some factors that improve HIV care and retention in upcoming slides. And Riley, you're on mute.
Yep, we know that transgender people living with HIV are accessing or interested in accessing gender affirming care, including hormone therapy and surgeries. So that same study of transgender women in 7 major US cities found that 77% of HIV positive transgender women were currently taking hormones, and an additional 15% wanted to take hormones. And because of that high desire for hormone therapy, this might be an entry point to care for transgender women living with HIV, and at times even more so motivating than necessarily accessing care for HIV. Unfortunately, we don't have adequate data on transgender men with HIV who are accessing gender affirming care. We do have data from the US National Transgender Survey, which was a large national survey of transgender people, but was not specific to people with HIV. But that study found that 69% of transgender men had accessed hormone therapy, and another similar percent were interested in accessing hormone therapy. And then when we look at gender affirming surgeries, so the NHPS survey that we've been talking about, that found that about a quarter of HIV positive transgender women had had some form of gender affirmation surgery, and about half had not had surgery, but were interested in having surgery. And again, we don't have that data for transgender men with HIV, but looking at the overall population of transgender men from that same US transgender survey, found that high percentages, around half of men had like top surgery, and about half wanted that someday. And then slightly lower rates, about a quarter had like bottom surgeries like hysterectomy or phalloplasty, and about a quarter reported wanting those someday. And we can likely assume that those rates are similar for transgender men living with HIV, but again, that topic should be studied further because we don't currently have the data. So we know from the epidemiologic data that transgender people are disproportionately affected by HIV, and that transgender people with HIV are accessing or interested in accessing gender affirming care. Yet there are multiple reasons why transgender people might struggle to access care for HIV, or that people living with HIV might struggle to access gender affirming care. So multiple studies have described the discrimination and mistreatment that transgender people face when accessing healthcare. And that includes having to teach healthcare providers about transgender identity, being asked unnecessary questions about their gender, facing verbal harassment or abuse, or even being refused care. And transgender people who have experienced discrimination or abuse in healthcare or in other aspects of their lives might be hesitant to seek treatment or testing, even for HIV. And furthermore, we must consider the intersections of transphobia and sexism and racism and how those contribute to the disparities that we see, particularly amongst transgender women of color. So we're beginning to learn more about the connection between access to gender affirming care and access to and adherence to HIV care. And the data is still a little bit mixed. So one study on women living with HIV in San Francisco found that transgender women on hormone therapy had higher odds of being on antiretroviral therapy compared to those who were not on hormones. Another study from Baltimore found that people who have an unmet need for gender affirming surgery, so people who wanted gender affirming surgery but were unable to get it, or wanted hormone therapy but were unable to get it, that correlated with higher rates of having their HIV treatment be interrupted or having poor adherence to HIV medications. However, there's some studies that actually found the opposite, where some patients might prioritize their HIV care or might prioritize hormone therapy over their HIV care, and that adherence to hormones correlated with an increased viral load. So again, some mixed data, kind of depending on which study we're looking at. Possible explanations for that include patients having concerns about potential adverse reactions between their hormones and their antiretroviral therapy. And that's something that we're going to talk about some in this presentation. There's also just the time and cost associated with going to multiple appointments and multiple different clinics to get this care, the pill burden of being on multiple medications, and all of that might cause a patient to prioritize taking their hormones over their antiretroviral therapy. And those concerns can be addressed through patient education and patient-centered care, all of which we're going to talk about. So again, most of these studies were unfortunately limited to transgender women, but given the known disparities that exist for all transgender and non-binary folks accessing healthcare more generally, we can likely assume that transgender men and non-binary people face similar challenges with HIV-related care. But again, that's an area that can be studied further. So when we talk about integrating HIV care and gender affirming care, there's a lot of different models and ways that can look. And a lot of people, we saw this in the response of just the folks attending this webinar. So some clinics might have fully integrated care where it's the same providers prescribing antiretroviral treatment and hormone therapy, and they serve as a patient's primary care provider. And some benefits of that approach are that the patient can form a relationship with one provider who knows them well, they build trust in that relationship, they save time and money by not having to go to multiple different appointments, and it reduces the risk of miscommunication between providers. The downsides are that does require that the provider have the training, experience, and comfort with that full scope of care. And in some cases, those visits can be, it can be a lot to tackle in one appointment to handle all of the HIV-related care and the gender-affirming care. So another approach is having multiple providers kind of under the same roof, with some doing HIV care and others doing gender-affirming care. And that lets folks kind of feel connected at one clinic, while reducing the pressure on individual clinicians to provide both types of care if they don't have the training necessary to do so. So that facilitates communication between a patient's various providers and allows for concentration of resources like pharmacists and social workers and care navigators all in the same place. Some downsides though, again, if patients are having to see multiple providers, that might place an additional burden on the patient in the way of time or copays or just convenience. And then lastly, some practice settings are a more siloed approach where there's one clinic that does HIV care, and then they maybe refer out to a different clinic that does gender affirming care, and whether that's within the same institution or it's a nearby clinic in your community. I think that's a more traditional model where these are each seen as separate specialty services, where maybe there's some overlap, but they're managed more independently. And that referral model might be challenging for patients to navigate, and the communication between providers becomes kind of more time consuming and with more space for error there. So thinking about how your clinic functions, now that we've kind of talked through a few different models of care, I'd love to hear from folks in the group here about kind of what model are they practicing at your clinic, and what are the pros and cons that you've experienced in the way that you're providing care wherever you're at. And please feel free to unmute or type in the chat, whatever is easiest for you. And we'll try to monitor the chat.
I know some folks came in a little later, but we did do a poll looking at different people's clinical settings. So some of you don't provide clinical care and others do provide clinical care. So we're sort of curious for those who do what your current models are.
Ms. Jai, you have your hand up. Go ahead.
Yeah, I was thinking about the last clinic that I worked in, and we took an approach that was similar to the third option, where it was referrals from, I worked at an infectious disease clinic for patients who were living with HIV, and we were referring out for gender affirming care into the same health network, but to a different provider. And some of the challenges with that were either referrals wouldn't go into the system correctly, or we would refer someone to a provider that we thought was doing gender affirming care. But then when the patient followed up, they actually weren't doing gender affirming care, or they weren't familiar enough with it. And so we had a lot of kind of like dead end referrals happen as well.
Thank you for sharing, Ms. Jai. I believe others are typing things into the chat, so please feel free to raise your hand and tell us about your experience. So we have one response. I believe we are a fully integrated care model. We have providers who do both HRT and ART. Well, one con, I think, is that those providers get very overbooked because they are very much in demand, both by HIV patients and patients who want HRT and patients who want both. Thank you for sharing that.
I think these comments are very insightful and also kind of consistent with my experience in different clinical settings. Some of the challenges of referrals, although sometimes referrals can work well, and definitely there are some challenges with incorporating both services into your own clinic, particularly with limited providers. Should we go to the next question?
Yeah, so kind of thinking more deeply into that.
Riley, there's two more comments. One says, I'm at a fully integrated clinic as well, and experienced some of the same issues that the previous commenter brought up. And then a final comment says that there's also a perception that we couldn't do gender affirming care because we believe it was not covered by ADAPT or Ryan White Care. Just wanted to share those comments. Thank you, everyone.
Great, thank you, Ty. And thank you to everyone for your responses. So kind of, again, exploring that a little bit deeper, what barriers have people encountered, or could you anticipate or foresee encountering if you tried to switch to a different model of care? So if you tried to do something different from what you're currently doing at your practice, has anyone attempted that? Or it sounds like the issue of insurance coverage came up for one clinic, which was certainly a consideration. And again, please feel free to chat or just do the little hand icon and we can call on folks.
I believe we are getting some things typed into the chat, but in addition to coverage concerns by ADAPT and Ryan White, what other barriers have people experienced? structural barriers, only 20 minutes available for each appointment. Also concerns that we may get in trouble from the hospital administration for providing care outside of the infectious disease capacity. So two different types of concerns. One is a structural concern about appointments, and then also going above and beyond and what kind of repercussions. Thank you for that comment. I think there's one additional one that we're waiting for. Another one is lack of providers in the community who provide transgender care /HRT. As someone who has access care through a specialty care model, I've seen patients have difficulty getting appointments scheduled. The providers either A, were in high demand, only one person /coordinator at the clinic who could make appointments with those providers who provided care. So once again, some structural issues around the availability of appointments, and then just a lack of providers.
Mhm.
Another one coming in, capacity building. Staff may need to polish up on providing client-centric care that is gender affirming. And thanks, that is the purpose of our webinar today, to help start people in that polishing up stage.
Wonderful. Thank you, everyone, for that discussion. And please feel free, as you think of things, to continue to type in the chat or to raise your hand. You know, thinking through some of those barriers, so ones that we had kind of thought of, again, that lack of provider education on prescribing HRT, or for people already doing HRT, maybe if they're not doing HIV related care yet. And we're hoping that, you know, through webinars like this, we can increase provider comfort, and we can also make folks aware of the resources available to support ongoing education on this topic. There's also, you know, lack of time, right? Someone brought up the 20-minute appointment. This can be a lot to cover, especially if it's one provider doing all of this care. But, you know, trying to find ways to troubleshoot and work within the limitations of your own clinic. But whether that's more frequent appointments or managing expectations, the insurance coverage can be a big piece. So especially if people are, you know, if you're getting Ryan White funding or something, or if patients are uninsured, they might have trouble accessing gender affirming care. So trying to get connected with resources like enrollment specialists who can help get folks coverage, advocating on the state or local or even the national level about coverage for gender affirming care are really critical to this work. So patient perceptions about taking ART and HRT, again, this was something that some survey data has shown us that patients might believe there's interactions, and that might affect their willingness to take medications or to seek care for both issues. And then just patients feeling comfortable bringing up their gender identity in the clinic setting where they're getting their HIV care, or even requesting HRT, kind of depending on how welcoming they view that clinic to be. And then lastly, the access to specialist referrals. So I think anyone who's providing any level of care has had at least some issues with referrals, depending on what type of care you're providing. And so the same thing exists if you're trying to refer folks out for gender affirming care. There might be challenges there.
I'll just add a couple more things on that last slide. In terms of the time issue, you know, we do want to empower everyone to ask their patients for more frequent appointments. Sometimes you just don't have time to get everything in. So it's important to set expectations, as all providers know, which is, you know, easy done, but also absolutely fine to do more frequent appointments, and to really kind of insist on that. But really our goal of this, as was stated earlier, is to improve education among providers so that we do have more folks who are cross-trained and able to provide both services to their patients. Another note on insurance coverage. You know, in some states, obviously insurance coverage is so variable state to state, Medicaid expansion, but in states that are really relying heavily on ADAP coverage, you know, I think many times you can absolutely make the case that hormone therapy is HIV care, given the massive amount of data about adherence to HIV care for folks who are receiving the appropriate hormone therapy. So in some ways that should be a covered service by ADAP. I think having a close relationship with your insurance cover, your enrollment specialist is also important. And then having nursing staff and other support who can help with the prior auths that may be needed, and getting more familiarity there. But also in places where being cross-trained is not a possibility, specialist referrals, we do encourage people to build up their networks and even to look and see if there are any telehealth models that could be leveraged for hormone therapy, given that that's really a growing option for people. Okay, thanks. So now we'll move into our case. We have a case discussion, and we'll talk about providing HIV and gender affirming care, including medication management, monitoring, and preventative care. So to start, let's think about the next case. So this is Monica. She's a 48-year-old transgender woman who was diagnosed with HIV in 2008. She was previously well connected with an HIV clinic and was on a tripla. In 2015, she came out as transgender and began exploring options for how to start feminizing hormone therapy. At the time, the HIV clinic that she used primarily focused on HIV-related care for men who identify as gay. Monica did not feel comfortable going to this clinic presenting as a woman, so she started missing more appointments and was eventually lost to follow-up and ran out of her ART medications. She started using injectable estrogen that she bought from friends and online. She has since presented to the emergency department a few times and most recently was diagnosed with pneumocystis pneumonia. Her recent ER visits have motivated her to re-engage in care, and she's now interested in restarting her HIV treatment. She's also learned that her health insurance will cover gender affirming care, and she would like to start prescribed hormone replacement therapy and pursue vaginoplasty or bottom surgery. So as a group, let's discuss Monica's case. So imagine it's 4 p.m. on a Friday, your staff's itching to go and get on with their weekends, and Monica shows up to her 30-minute visit to establish care with you. What else do you want to know about her? How would you approach this encounter? Feel free to unmute or raise your hand or type in the chat and let us know your thoughts on what would be on your mind when this patient came in.
As people are typing, just remember the question is in the chat. So as Dr. Rowan set it up, it's 4:30 Friday. Monica shows up. People are ready to start their weekend, and Monica is ready for her appointment. How do you approach this encounter? Tell us what's going through your minds. Type it into the chat or raise your hand. While people are typing, I think what would be going through my mind, Dr. Rowan, is how do I adequately talk to Monica and use our time wisely and not try to rush through this because I'm feeling the urgency to start my weekend. And I'm just being honest about my response.
Yeah, that's a good self-reflection.
We have a hand raised, Ms. Jai.
Thank you. I think the first thing I'd be thinking about and would want to know more about Monica is what her first goals are. So like all of these goals seem like they're going to take some time. And so I would want to ask her more about what her health goals are and how she would like to move forward, instead of just approaching it as the provider and saying like, well, let's get you back on your AAA. Let's start these pieces because she might not be ready to jump back onto the medication.
Thank you, Ms. Jai. There's one comment, welcome her, check in on how she's doing with medications, and check in on any issues she might be experiencing. I see some more things are getting ready to come through the chat. Check on any issues that might prevent her from retaining in care, such as transportation to appointments. Yes, that's a good point there. What else is going on in Monica's life that would help us help her? Transportation is a part of that. Thank you so much.
Just clicked a little early. Sorry, I was gonna say, I think that's a good transition to think of what are some of those factors that led Monica to be kind of lost to follow up when she first started her transition. And feel free to answer both these questions kind of in the same discussion.
And Dr. Smith, there are two other comments. Check in on Monica's mental health status. Discuss exactly what Monica hopes and expects from the care she is receiving and planning to receive. And now we are ready to really think about what factors might have really influenced Monica to be lost to follow up when she started her transition. So thinking about what we learned about Monica. And Dr. Rowan, could you repeat some things about Monica just to remind us?
Yeah, so she was diagnosed with HIV in 2008 and was receiving care at an HIV clinic on a triplet. Around 2015 is when she came out as transgender, and she was going to a clinic that in 2015 was largely focused on serving gay men, gay cisgender men. And so she eventually stopped taking her ART and stopped going to appointments at that clinic. She did start taking some injectable hormones, some that she'd gotten from friends, and then she was able to order some online. But being off ART, she started to experience some immune suppression, and actually was diagnosed with pneumocystis pneumonia in the emergency department. So at that point, sort of a call to action to re-engage and start addressing HIV again. So she is doing the brave thing of coming to an appointment. And the only slot that was open was the 4 p.m. Friday slot. So here she is.
Thank you. So that was a lot. So you heard Dr. Rowan go through some of those things. So what factors did you hear that really contributed to the loss to follow-up? Type those into the chat or unmute. We would love to hear people's voices. Voices are a very beautiful thing.
And obviously, it's a hypothetical, so nobody knows Monica personally, but anything that you've seen in patients or anyone you know who might have had a somewhat similar story and what their experience had been, if they had been on and off of HIV medicine or in and out of HIV care.
Not having a point of care when she saw herself reflect, not having a point of care where she saw herself reflected in the clientele. Thank you, that's important, not seeing herself reflected. What other factors do we think as an audience has really helped contribute to that loss to follow-up? I would also want to work with her to get some baseline labs so that we know her viral load, CD4, and hormones are at. Some of the factors that contribute would be discomfort with receiving services where she may be perceived as being cis male and not having services where she could get gender affirming care. Yeah, thank you. That was really important that she did not see herself as being able to really kind of bring her full self to the clinic, being belonging. Thank you, Sarah. We can, Dr. Rowan. Oh, one more. Having access to HRT on her own could be difficult and not leave her enough time and resources to it. assess ART as well.
And, I'll just add from my experience, I think sometimes people feel like they may be scolded by their provider for getting medication that wasn't through prescription. And that definitely doesn't make you feel excited to go see someone if you think that you're going to be told that you did something wrong. And she just learned that she has insurance coverage and that will cover gender affirming care. So she could have also believed that her care wouldn't be covered. And so what was the point of discussing gender affirming care? Absolutely. I think that happens pretty often. So if we look at this next slide, I think there's one more from the chat. Oh yeah, okay, that's Misty's. That's the stars. So, there is a lot to cover, and hopefully, like Ty said, you're able to keep your head in the game and not just think about Friday and the weekend. This won't be all tackled at one visit. We know there's a lot to unpack. Like everything else in medicine, this requires some triaging, agenda setting, shared decision-making, because whatever is the highest priority for you may not be the highest priority for the patient, as was mentioned by multiple people in response already. That said, one of the most important goals of this visit should be to establish trust and re-engage the patient in care. This starts the moment the patient walks in the door. So we want to be sure that the first touch, whether it's when they call to schedule an appointment, look your clinic up online, given that many people have already seen your website before they even pick up the phone to make a call or submit a scheduling request. All of those things will influence the way people feel about our clinical services. Ensuring that all clinical staff are comfortable asking for and using a patient's correct name and pronouns, even when that's different than what's in the chart. Marketing materials that feature gender diverse clients are really critical, including body types and races, having gender neutral bathrooms in the lobby. These are just some of the ways that we can create safe spaces that are welcoming for patients of all gender identities. So once the visit starts, we would at a minimum want to get a past medical history, high level, past medical history, review current medications. Is this person getting medical care anywhere, taking prescribed medications, taking non-prescribed medications? Do a review of systems, screening for any alarm symptoms for opportunistic infections. This is someone who is certainly at risk for opportunistic infections, given that they've already been diagnosed with pneumocystis. We want to see how the pneumocystis treatment went or is going, if they're still taking that those antibiotics. We want to get some baseline labs. So would also then kind of want to turn to what are going to be the barriers to care and the barriers to following up for a second appointment. What are the immediate barriers to care? Does Monica have health insurance? Does she need help with transportation to appointments? Does she need to see our social worker today or connect with an enrollment specialist? And then if there's no signs of opportunistic infection, we would want to consider restarting HIV treatment today. And so I'd say something, to the effect of, if you're ready, we can restart your HIV meds today. For me, in my practice, I would say Biktarvy is a medicine that we commonly start people on when they're coming back to care or have just gotten diagnosed. So, if you would like to start HIV medicine today, there's no reason not to, assuming there's no evidence of really, only very few opportunistic infections that would even prevent you from starting ART immediately, if that's what the patient wants. Let's also get some labs. And if there's any concerning results, I'll give you a call. So let's make sure I have a good phone number for you. We'll discuss your labs if there are any concerning results. And then let me know if you have any trouble picking up the prescription. You can let me know today or let me know next Monday. So we will discuss initiation of hormone therapy in the next few slides, but we're generally pretty liberal when starting medications, so long as the patient clearly meets criteria for gender dysphoria, has no contraindications to hormone therapy, and is able to provide consent. Particularly for patients who are already accessing hormones through non-traditional or non-prescribed means, we do absolutely advocate a harm reduction approach with the thought that hormones we prescribe are almost certainly going to be safer than what the person's acquiring online or through other channels. So we would rather get them access to safe hormones as soon as possible than delay for any reason at all, really. It's also important to remember, as I think many people probably here know, that accessing hormone therapy might be a much higher priority than HIV therapy for a number of good reasons. So thinking back to our conversation about barriers to care, remembering that offering hormone therapy may be our entry point to HIV care for transgender persons, as long as they feel welcomed and affirmed in the clinic. So as a clinician, you might think that the more urgent issue, particularly given that the patient has had a recent opportunistic infection, is HIV medication. That may not be their priority. And so it's really important to work with the patients to find the balance while also expressing your medical opinions about the importance of HIV treatment.
All right, so wonderful. So now diving in a little bit more into the actual initiation and management of both HIV medications and hormone replacement therapy. So when initiating hormone therapy for all patients, including people living with HIV, there's a few aspects to consider. So first, does this patient meet criteria for gender dysphoria? Can they provide consent? And are there any like physical or mental health concerns or medication interactions that we need to be aware of? And we're going to go over some general guidance and considerations for all of these over the next few slides. So I'm not going to bore anyone by reading this, but we're certainly not going to dive into the depths of the DSM-5, and we're not necessarily using this as a diagnostic tool. This is something used by mental health providers, but can also be, is good to be familiar with as a way of diagnosing gender dysphoria, and can help make folks more comfortable in recognizing kind of the requirements for making that diagnosis and to support your gender expansive clients. So I'm not going to read through the full criteria, but the main components are that incongruence between one's experienced or their expressed gender and their natal or their birth gender that's lasting at least 6 months duration, and then marked by some of the features listed here. So experienced providers are likely comfortable assessing whether a patient meets criteria for gender dysphoria themselves based on these criteria. Other providers might use a behavioral health colleague to help make that determination. In the updated WPATH guidelines, they don't specify it. They say that can happen either from a healthcare provider or a behavioral health provider. And whatever system you're using, I do encourage you to consider if you're putting up unnecessary barriers for your patients and kind of what is the function of those barriers. So for example, if there are no gender affirming behavioral health providers in your area, requiring something like a letter from a therapist or an assessment from a behavioral health provider might place an undue burden on your patients if they're having to find that person that doesn't exist in your community. Excuse me. Regarding informed consent, so there's nothing really special or specific to hormone therapy about this in terms of assessing someone's ability to provide consent. I talk about this the same way I do with any discussion about a medication or a procedure, which is just to make sure that my patient understands that hormones do cause some irreversible changes. There are some risks associated with them, and they do require ongoing monitoring in order to use safely. And so I go through all of that with the patient, and we'll talk more about each of those factors. Some places use like a written consent form, and other places just use verbal consent for hormone therapy, and either one is okay. So in terms of medical considerations and things to be aware of when starting feminizing hormone therapy, the UCSF guidelines do recommend getting some basic metabolic panel just as a baseline labs if you're using spironolactone as the anti-androgen, and we'll talk more specifically about the medications that we use. Someone had brought up checking baseline hormone levels, like an estrogen or a testosterone level. I generally don't find that helpful as a baseline unless someone is already taking hormones, whether they're prescribed or otherwise, or if you're evaluating for an intersex condition. And that's consistent with the UCSF guidelines. So typically the main lab that you'd be getting is a basic panel as a baseline. And then for estrogen therapy, so the only absolute contraindication is an active estrogen sensitive cancer, but there are some other kind of relative contraindications or things to consider prior to starting estrogen therapy. So a personal or a family history of venous thromboembolism. Again, that's not an absolute contraindication, but we do know that estrogen therapy is associated with a higher risk of venous thromboembolism. So patients should be evaluated and counseled on that, and anticoagulants can be considered depending on the patient's history. And the UCSF guidelines have a really helpful workflow for thinking through that if that comes up. Modifiable risk factors, so things like tobacco use, should be modified as able. We know that estrogen has the potential to increase the risk of cardiovascular disease. And again, that's not an absolute contraindication, but emphasizing modifying other risk factors, helping patients better control their chronic diseases like diabetes or high blood pressure. But the baseline here is it is really important to remember that for many folks, hormone therapy is an absolutely essential and potentially life-saving medical treatment. So it really should not be withheld unless it is like truly medically necessary. And then, finally, the last point here. So for both feminizing and masculinizing therapy, patients should be counseled on potential effects of fertility. So we know estrogen therapy can cause testicular atrophy and reduction in sperm count that can impact future fertility. So sperm preservation is an option if patients are interested in that, and that's best done prior to starting hormone therapy.
And then a word about the HIV medication interactions for feminizing hormone therapy. So you'll note here that the effects on estrogen are variable. Protease inhibitors with ritonavir boosters, efavirenz, etravirine, and nevirapine can decrease estradiol levels, whereas the effect on estradiol levels is highly variable for elvitegravir with cobicistat, which is commonly known as Genvoya, and protease inhibitors with cobicistat, which are used but not nearly as frequently as some of the other HIV regimens that we use. And so the recommendation from the HHS guidelines is really to monitor estrogen levels and to go from there. So none of these are absolute contraindications, but they may have some medication interactions. And then looking over at spironolactone, which is used for its anti-androgen effect for its anti-androgen effect. There's not any significant interaction with antiretroviral therapy. The only main interaction that we see is the risk for hyperkalemia if taken with Bactrim. And patients such as Monica that we discussed in our case will probably be on Bactrim for PCP treatment or PCP prevention, or PJP, depending your preference on the terminology of the acronym for pneumocystis jirovecii pneumonia. So that is a potentially significant interaction and something that we do monitor for, not an absolute contraindication by any means, but we do keep a close eye on potassium levels in those cases. And then finally, some patients use finasteride or I don't know, do you say dutasteride or dutasteride? I don't even use that medication. So, but these do have anti-androgen effects as well, and they can prevent, some people use them to prevent hair loss. So elvitegravir with cobicistat can increase concentrations, and so patients may need to be monitored for adverse effects. And in some cases, the finasteride concentration, the finasteride dose could be lowered. In contrast, efavirenz, etravirine, and nevirapine can decrease finasteride concentration. And so in that case, finasteride may be less effective and you may need to use a higher dose. So just to kind of summarize, the concerns about hormones with antiretroviral therapy, as well as the antiandrogens and Bactrim, which is often used for PCP prevention and treatment. You'll notice that most of the most commonly used HIV medicines are not on this list, meaning that there are no significant drug interactions with commonly used HIV medicines and medicines used for hormone therapy. In the cases in which there are interactions, you can turn to the HHS guidelines where they have a really clear section on basically what is on this slide, what the interactions can be, and what the monitoring should be in response. Okay. Next slide.
All right, so now looking at some of those same considerations for masculinizing hormone therapy. So guidelines recommend getting a baseline hemoglobin and a pregnancy test if applicable. And the only absolute contraindication is an active sex hormone sensitive cancer or pregnancy. So testosterone use during pregnancy can iatrogenically affect the fetus. So patients with the potential to become pregnant should be counseled and should use reliable contraception. Other relative contraindications or things to consider include severe hypertension, sleep apnea, or polycythemia, which is elevated red blood cell counts. Those all can potentially get worse with testosterone, so ideally they should be well controlled prior to starting testosterone. Testosterone can also raise cholesterol and increase the risk for metabolic syndrome. But similar to our discussion about feminizing therapy, these are not absolute contraindications, and you really should just engage your patients in a risk-benefit discussion and work to control modifiable risk factors.
And then turning to the ART interactions with testosterone. So for patients, there are a few medication interactions to be aware of. Again, not as common as some might have feared. But efavirenz and etravirine and nevirapine can lower testosterone levels. So in those cases, patients might need higher doses of testosterone to achieve the desired effects. And then elvitegravir with cobicistat and all the boosted protease inhibitors may increase testosterone levels. So doses may need to be lowered. Testosterone doses may need to be lowered, and patients should be monitored for signs of adverse effects. And again, these are less commonly used HIV medications, although certainly those who do HIV care know that elvitegravir with boosted cobicistat in the form of Genvoya is still used, though certainly not first line anymore. And similarly, protease inhibitors are used some, so it's important to be aware of those things. And so if a person wants to, they can certainly be switched to a different ART regimen, given that we have so many options. But if they don't want to, you may just need to pay a little extra attention to make sure that the person's on the optimal dose of testosterone. There's certainly no absolute contraindications really for any of the medications we've talked about so far.
All right, now, so thinking back to Monica, what labs would folks want to get at her first appointment? I might just give folks a minute to think about this, and if you want to put in the chat, that's great. Or you can unmute. Probably for the sake of time, I'll probably click through pretty.
And this is a safe environment. This is not a test. If you don't if you don't get the right answer, don't worry. We will still send you some lovely chocolate chip cookies.
I think earlier Miss Dry had already, I think it was Miss Dry had brought up wanting to check on like a CD4 count. I think a viral load might have been mentioned.
Yes, so the exact response was her viral load, CD4, and hormone levels.
Awesome.
I have
so go ahead.
Oh, sorry. I was just going to say I have a follow-up question. So since Monica was already taking hormones, would you do a check of like where her hormones were at since they were non-prescribed, or would you just start with a basic metabolic panel and then do follow-up labs after prescribing?
Yeah, great question. So first off, I think the guidelines there's not like one specific right answer to that. In terms of kind of practice style, I've seen it done both ways. I think if you are going to be prescribing hormones that day, it might not really make a huge difference. I think checking hormone levels, after someone's already been on what you're prescribing is more important than necessarily where they're starting from. So if someone, is actually though getting prescribed medications and you're going to be continuing, then I think it's helpful if you're continuing what they're already taking. But again, no real right or wrong. So looking through some of the HIV-related labs, this is something that providers who do this care, it's the same thing you would do for any patient, regardless of their gender identity. So we talked about CD4 counts, viral loads, some comprehensive metabolic panel, blood counts, lipid A1C, some viral screenings and STD screenings. And then for the HRT labs, it's not a ton. So the basic metabolic panel, again, if we're thinking of starting spironolactone, and then hormone levels, maybe. I don't think there's a right or a wrong. But it might not affect your management if you're already going to be prescribing hormones. So in terms of the counseling, here's a really nice overview for kind of the anticipated changes with feminizing hormone therapy and a timeline for those changes. So this is something I often give to patients at that first appointment. It's important to counsel folks that the breast growth and changes to testicular volume and sperm production are typically considered permanent or irreversible, even if they were to stop hormones down the road. So I'll give folks a second to kind of look through that. And then here's the same information for patients starting testosterone or masculinizing hormone therapy. And for this, the face and body hair growth, hair loss, clitoral enlargement, and deepening of the voice are generally considered permanent or irreversible, even if hormones are stopped at some point down the road. And then we already discussed some of the risks associated with hormone therapy. This table is from the WPATH Standards of Care 8 guidelines that summarize those risks nicely. So for estrogen-based regimen, we're thinking about venous thromboembolism, effect on fertility, metabolic and cardiovascular risk, and then the hyperkalemia or elevated potassium levels with spironolactone. And then for testosterone, we think about polycythemia or increased red blood cells, the effect on fertility, acne, metabolic changes, cardiovascular risk. Okay. So I know that was like a lot of information and what questions do people have about some of that counseling, either in general or specifically as it relates to people with HIV?
And feel free to unmute or type your questions into the chat. If you do not feel comfortable asking your question today through the chat, you can email me. I will put my email into the chat and I will send the questions over to Dr. Smith and Dr. Rowan and email their responses to you.
Hi, is anyone typing?
I don't see anyone typing, but I would say give it another 30 seconds and then we can go on. All right, Dr. Smith, go on over to your next slide.
So once we've decided to move forward with hormone therapy, there's a number of regimens that we could choose from. So for feminizing therapy, estrogen comes as an oral pill, as a transdermal patch, or as an intramuscular injection. And the guidelines recommend transdermal estrogen for patients with a high cardiovascular risk or who have a history of blood clots. But otherwise, the delivery method can really be chosen based on patient preference. And there's not really any specific considerations based on HIV status or HIV medications. And again, these are all, specific images are from UCSF, but are also based on WPATH guidelines. So are a helpful resource for folks if you want to look at it in the future. And then we've been talking about anti-androgens. So spironolactone is the most commonly used one in the United States, but some people are on finasteride instead or in addition to spironolactone. And here's the common dosing for that. And remember the potential for hyperkalemia with the spironolactone in patients on Bactrim is the main thing to think about here. And then for testosterone, that can be administered transdermally as a gel or a cream or a patch, or intramuscular or subcutaneous injections. And this just entirely depends on patient preference. There's not really any right or wrong way to do it. And again, these are all pulled from UCSF, so you can reference those in the future if needed. Okay, any questions on the specific medications we use?
We do have a hand raised. Ms. Jai?
Less of a question, but just more so a comment that even though all of these medications are available, one of the challenges we found is that insurance won't cover certain types of medication. And so one of the ways that we've been able to be supportive as providers is potentially doing the prior authorization work or helping to provide information to insurance as to why a certain type of medication is being provided or is being prescribed.
Yeah, great point. I've generally found the oral estrogen is usually the least expensive. And then the injectable testosterone is typically the least expensive if people are using GoodRx coupons. But again, there might be medical reasons why you're wanting to use a different method. And so we can use that to advocate for our patients with insurance companies.
I'm not seeing any other questions, Dr. Smith.
All right.
Should I take over? Thinking back to Monica? Okay, yeah. So hopefully everyone memorized all those tables, but really very helpful introduction. And so we'll kind of get back to Monica and her baseline labs, as might be expected, she had detectable HIV level because she's been off of HIV treatment for a while. Her CD4 count was low at 120. She had normal liver and kidney function, normal blood cell counts, and normal lipids. And she had said, yes, she would like to start Biktarvy at that last visit. So she's now started Biktarvy. And we did choose Biktarvy due to its convenient dosing, minimal drug interactions. It's really a pretty commonly used medication for those reasons. And so she's completed her course of Bactrim for PJP, the 3-week course. It's a lot of pills. It's a lot of medication. So now she's happy that she can go down to just 1 DS daily Bactrim pill for prophylaxis. So now she's on Biktarvy and daily Bactrim. And so she is interested in starting hormone therapy. So now we could ask kind of what are some of the medications you could start for hormone replacement therapy? And I don't know if anyone, wants to make a suggestion or just to sort of think back to some of the options that we talked about in the charts on those prior slides. I'll give it a second if anyone has any comments or suggestions. Or in the interest of time, I could kind of let you know what we gave our patient, Riley and I, in consultation. Actually, I've been well trained now, so I can do it all by myself. So Monica chose to start injectable estradiol valerate 10 milligrams IM weekly. She had been on injectable before and felt that that was the most effective based on her experience. And so through shared decision-making, we decided that that would be a good option for her. So that was what was prescribed. And we also started spironolactone 50 milligrams BID, so higher than we'd be using for hypertension or heart failure, but the appropriate dose for hormone treatment. Because she was on Bactrim with the high doses of spironolactone, we were cautious about hyperkalemia. And so we had checked a BMP, her potassium was normal, and we asked her to come back in 2 weeks and again in 1 month for repeat labs to make sure that she has normal renal function and normal potassium. If she hadn't been on Bactrim, those extra blood tests would have been unnecessary, and we could have waited about 1 to 3 months to make sure that she wasn't having any adverse effects from the spironolactone. So when she came back in a month, her viral load was close to suppressed, and her CD4 count had increased to 160. Okay, when would you want to see her back in a month? And let me see, I think Riley's going to talk about the monitoring.
Yeah, so we chose to bring this patient back more closely because of monitoring the potassium, but otherwise could bring her back in a month or so. Some people will check a basic metabolic panel at that 1 month visit, particularly again if you're concerned about kidney function or about high potassium. And then in terms of hormone levels, we usually check those along with the BMP every 3 months or so for the first year of treatment. And then yearly, or kind of with dose changes can also check. For hormone levels, we target the cisgender female physiologic range of about 100 to 200 for estrogen, and then aiming for suppression of testosterone to below 55. Although again, those are not like hard rules. Can all kind of depends on what your patient's goals are and how they're feeling about how things are going. And then for testosterone, here's the same table with kind of information on monitoring. So again, you're checking hormone levels, which we typically just check a total testosterone. There's not really much utility in trending like estrogen levels. And then checking blood counts every 3 months or so. And again, with dose changes, can check or about annually. We similarly, we target a testosterone range similar to that for cisgender males, which is a really wide range. So anywhere from like 300 to 900, again, based on our patient's goals. Okay. Any questions about the monitoring side of things, or what kind of the thought process was for when we would bring Monica back, or what medications we would start for her?
I'm just gonna ask, Riley, do you have a most commonly started estrogen regimen? That's sort of your go-to if someone has absolutely no preference.
I think I typically would lean on either pills or injectable, just based on whether a patient thinks they can remember to take a pill every day, or if they're willing to do an injection. I think most patients have an opinion of one of those over the other. I found the patches are a little bit hard to titrate, and sometimes patients have issues with them like staying on, or get some skin irritation.
No questions in the chat. Oh, just as I said that, would monitoring move to an annual monitoring after the first year, assuming that levels were consistent at the 1 year mark?
Yeah, so if someone is on a stable dose for their hormones, you can check just annually. And a lot of people, and consistent with the guidelines, you don't even necessarily need to check hormone levels every year. I'll check them if a patient is having kind of changes in their symptoms, or if they've had really significant like weight changes where you think their body might be metabolizing the hormones differently or something. But many people who are on a stable regimen for a long time don't need as frequent monitoring. You do still like to check an annual CBC for people on testosterone to check their blood counts, and an annual metabolic panel for people on spironolactone to check their kidney function.
Thank you.
And often these patients are getting more frequent monitoring regarding or relating to their HIV care anyways. And so, both the basic metabolic panel is kind of part of that like follow-up for HIV care, and as is the CDC. And so can really be nicely integrated into the follow-up patients are already getting.
What kind of counseling, if any, should a patient be giving if abruptly stopping HRT?
Yeah, so in terms of abruptly stopping HRT, one thing I tell patients is often they might feel really crummy. Depending on how long they've been on hormone therapy, there is that suppression of their body's ability to produce their own natural hormones. And so folks can kind of go into almost like a menopausal state in terms of the symptoms we think about for that. So people might have like hot flashes or mood changes, disturbances of sleep. Again, it's not as big of an issue if people have not been on hormones for very long, but can come up if they've been on it. And then reminding folks of what changes are considered reversible. So for example, if someone stops testosterone, then periods are likely to resume. And then what changes are irreversible, even if they do stop hormones.
No other questions, Dr. Smith.
All right. So we're going to talk a bit now about kind of the more general primary care and preventative screenings for transgender and non-binary people living with HIV. So many people who prescribe HIV-related care assume the role of primary care providers for their patients, and so I think this is important to bring up in this talk, just so folks are aware of the kind of screenings that that are indicated. Oh, I messed up my animation. Wait, there we go. Sorry. So Monica is now 50 and she's coming into clinic for her semi-annual follow-up. So she's feeling well. She's happy with the changes she's on since starting the prescribed hormone therapy. And now thinking through this list, this was just kind of a list that we made up of possible labs or screening tests. What ones would be indicated now? And you can just kind of read over this and then kind of think in your own brain or type in the chat any labs that you think you might want to get. We'll give people a minute just to think through. All right. So again, it's not a quiz, but these are the bolded ones are ones that we would think are indicated. Again, a lot of these are just part of kind of routine follow-up for people in HIV-related care. For her, we would want to check her estrogen and her testosterone level if this is still the first year of treatment. And then the italics ones here, it kind of depends, like mammogram and STI screening. We'll talk more about those, but some of it depends on how long she's been on hormones. And we'll talk more about all these cancer screenings in that.
So I'll just mention anal cancer screening, and based on the results of a very large trial, anal cancer screening guidelines have been updated, and we really finally have some more firm anal cancer screening guidelines, and really it's anal dysplasia screening. So it's recommended now that all adults with HIV over the age of 35 receive a digital rectal exam and an anal pap annually. And so for MSM and transgender women, this is a grade A recommendation, whereas for cisgender women and transgender men, this is a grade B recommendation. So it's sort of simplified it that it's really actually I think it's 35 plus for anal cancer screening now. And then for cervical cancer, it's really the same guidelines for all patients who have a cervix. So typically the cervix is removed as part of a hysterectomy for transmasculine patients, but it's important to confirm this with the patient. Transgender women who have undergone vaginoplasty or bottom surgery do not require cervical paps, but otherwise standard guidelines. And then breast cancer screening with mammography is recommended for assigned female at birth people who have not undergone mastectomy based on standard guidelines every 1 to 2 years starting at age 40 to 50. After mastectomy, most patients do not require further mammograms, but can consider annual chest exams or self-monitoring. And it's important to know that if a patient had a breast reduction surgery or a full mastectomy, given the residual breast tissue does change the recommendations. If they have residual breast tissue, they will probably still need mammograms. And then for assigned male at birth people, breast cancer screening should be initiated after age 50 or after 5 to 10 years on feminizing therapy.
And then some more cancer screenings here. So for colon, prostate, and lung cancer, those screening guidelines are all the same standard guidelines, kind of regardless of folks' gender identity. And then for osteoporosis, the guidelines are a little bit less clear. In general, DEXA scan should be considered for people of all genders with HIV starting at age 50. Also should be considered for transgender people who have had either like a hysterectomy or oophorectomy, or have had an orchiectomy, so if they've had removal of the testicles or the ovaries, and not been on hormones for 5 years, then they're at risk for osteoporosis and should be screened. Aneurysm screening for men with a history of smoking, and there's not really a clear consensus on how that can apply to transgender people, but something to think about in people assigned male at birth who have a history of smoking, or in people assigned female at birth who had been on testosterone for a while, so kind of arbitrarily 5 years or so, who have a history of smoking, it might be worth screening for them. And then finally, kind of circling back to the cardiovascular disease and smoking cessation. So smoking cessation is super important to talk about with everyone who uses tobacco, regardless of their HIV status or their gender identity. There are a few specific considerations in this population though. So we already discussed that estrogen increasing the risk for blood clots, and that risk is further increased in folks who use tobacco. And so because of that, really counseling patients on that, some people are not comfortable prescribing estrogen in patients who use tobacco. Kind of like we talked about previously, though, I think more of a harm reduction approach and educating patients and engaging in shared decision making and using topical estrogen to kind of limit that risk. And that's consistent with the UCSF guidelines. And then we also think that both estrogen and testosterone can potentially increase cardiovascular risk, as does HIV. And so talking about tobacco cessation in that context is also really helpful.
And just to kind of also mention, tobacco seems to have a disproportionately high adverse effect when people have HIV as well. And so regardless of hormone therapy, smoking really is associated with some of the top causes of mortality now for people living with HIV. So it's really, really a critical topic for our patients, critical and challenging. So any questions about preventative care for people with HIV and transgender or non-binary experience?
Dr. Rowan, there are none in the chat.
Okay.
And then we're just very briefly going to go over some perioperative considerations, just because this does come up sometimes. So for transgender people with HIV, gender affirming surgeries like vaginoplasty, phalloplasty, or vasectomy or top surgery, they're all pretty major surgeries. So they do require optimizing chronic medical conditions in order to be safely performed. And that can be a challenge for patients, and it can be a point of contention. So I think it's a great opportunity for us to advocate for our patients and use that trust that we built with them over time. So most surgeons will want a patient's HIV to be very well controlled prior to a surgery. And while we know that these surgeries are technically like elective in the sense that they're not emergent that need to happen today, they are truly life-changing surgeries that can be life-saving for our patients. And so I encourage you to work collaboratively with your patient and with their surgeon to set some reasonable goals regarding surgery and HIV care, as well as any other health issues like diabetes. And then regarding perioperative medications, some people will stop estrogen right before surgery to limit the risk of blood clots, although that's not necessarily evidence-based and not recommended or is not consistent with the guidelines in low-risk patients. Those folks can typically continue their hormones. And HIV medications should be continued. They should not be stopped around the time of surgery. And then after, if someone has had vaginoplasty with an orchiectomy, or if they've had a hysterectomy with oophorectomy, just if they have had vaginoplasty with orchiectomy, then anti-androgens like spironolactone can be stopped afterwards. The hormones can be resumed if that's within the patient's goals. And so for Monica, remember when she established she was interested in eventually undergoing vaginoplasty. So she's now coming back. She's been on hormones, she's feeling great, she's doing well. Her viral load is undetectable, and she is scheduled for vaginoplasty next month. And so she wants to know what to do with her medicines before and after surgery. And again, I know we just breezed through that super quick. So does anyone remember what do we want to do with her HIV medicines around the time of surgery?
There's no comment in the chat, so go ahead and tell us, Dr.
Okay. So we'll continue those. Remember, we definitely want to continue those. She can probably also continue her estrogen, and then she can stop her spironolactone after surgery. So that was, a kind of our blitz through a lot of information there. I appreciate everyone's comments in the chat and discussion, and we're happy to answer any questions that have come up for folks.
Let's give Doctors Smith and Rowan an applause, because this is a great webinar. Thank you for sharing this information. It is very needed. If you have questions, remember my email is in the chat. I can forward your questions to Doctors Smith and Rowan. This webinar has been recorded, so if you want to share it with members of your organization who weren't able to attend today, we will send out the recording. Misty, how do we send it out again? Please remind me.
Zami will usually send it out via email.
So it'll be coming out via email from me, I would say later this week or at the beginning of next week. One more round of applause for Dr. Rowan and Dr. Smith. Thank you so much for putting this together. This was a great webinar with a lot of knowledge. Thank you for your time. We're giving you 3 minutes back to your day. Use them wisely, drink some water, and have a great day.